Замечательно, спасибо.
Так, и я звук включу.
Да, звук
Всё
включил,
работает.
все работает, можно говорить сейчас.
Компьютер чуть-чуть подвис. Я быстро
Да,
туда.
ничего, все, спасибо тебе большое. Спасибо. Так, hello everybody. Let me know if you cannot hear me, or if you can hear me, let me know, so I'll be sure that I can continue. So today's lecture will devote to the questions of management of patients with diabetes in polyclinic and actual management of patients with diabetes at all. So, as you know already, we can determine diabetes mellitus as a chronic state of hypoglycemia due to deficiency of insulin secretion, its action, or both of it. So, can you hear me? Let me know. I can see in chat on the 2 students and 3, 4. Good. So, can you hear me? Please let me know. Okay, we can continue. So the term diabetes mellitus comes from the Greek word siphon and implies ferment of urine made, and mellitus means from Latin mello, that means honey or sweet, and was used because the urine was sweet. So diabetes is a huge and growing problem, and from it apparently cost society high and high price. So from 2013 to 2035, we expect almost more than half growing of patients with diabetes. So if we got about 400 million people in 2013, it will expect about 600 million people in 2035. So, as you can see, the problem is really huge. There is no prevalence between men and women especially after 65, 70 years in diabetes. So most, both men and women pretty frequent have this disorder. Pipeline of disease and escalating cause. So diabetes is not only widespread disease, but it's also caused a great number of complications and affected as soon as it is disorder of metabolism. Of course, it's affected in other organs and systems. So, as you see on this picture, that one of the main risk factors of diabetes, overweight and obesity, and a lot of people, more than half, comes to diabetes in 5-10 years. And the complication that caused by diabetes develop in 15-20 years. And complications of heart, as I said, it affect heart kidney, eye, and nerve system, and about 70 people with diabetes die of heart attack or stroke. About 20% of people with diabetes die of kidney failure. 2% of persons go blind after 15 years of diabetes, and actually about 20% of blind people in USA, for example, cause their blindness because of diabetes. And diabetes nerve disease affect up to 50% of people with diabetes, and especially so diabetes neuropathy is one of the frequent complications of diabetes, and when it combined with reduced circulation because of some blood of some heart cardiovascular disorders in legs, it has a great risk of foot ulcers and limb amputation. So there are several pictures that show us the quantity of people that suffered from diabetes. That is the data for 2013, but right now it's about the same prevalence, but a little, the numbers is a little more. But still we have that the great number of people of diabetes we have is Southeast Asia and Western Pacific, and also North America and Caribbean and Europe. Almost half of all people with diabetes live in China, India, and USA. It's also population, as you can understand. So that is top 10 countries of diabetes, prevalence of diabetes more than 25-30% of population. And don't forget that a great number of patients with diabetes is undiagnosed. It's about, you can see, from 24 to 54 and even 60% of patients not diagnosed. Diabetes is a frequent reason of mortality for people younger 60 years. And of course, don't forget about great expenditures. So diabetes costs a lot of money. The treatment, management of diabetes costs a lot of money. So at the conclusion, what I would like to say that diabetes is a widespread disease. No matter what specialty in medicine you will choose, you will meet patients with diabetes. The diagnosis of diabetes is not very difficult. As you know, you already got classes on endocrinology last year and probably this year. So as you know, the diagnosis of diabetes is not difficult. So basically, we have several criteria that basically level of fasting sugar more than 7 millimole per liter. And then glucose intolerant test more than 11.2, And for right now, we add one more criterion for diagnosis. It's glucosilate hemoglobin more than 6.5. So actually the diagnosis is easy, but still, no matter, we have a lot of patients with undiagnosed diabetes. And don't forget that diabetes cost a lot of money. Diabetes caused the development of complication, and actually the problem of diabetes is the problem of its complication. So I would like to remind you about several words about pathology of type 1 and type 2 diabetes. So as you remember, you're supposed to know this already. Yes, type 1 diabetes is characterized by destruction of the pancreatic beta cells in Langerhans islets. And most likely cause of this condition is combined genetic, immunological, and possible environmental factors. Actually, this abnormal means abnormal response of the body in which the antibodies are directed against the normal tissues. And this normal tissue, beta cells of pancreas became this normal tissue that immune system recognized as a foreign and produced aggressive antibodies. So it's reduce production of insulin or totally stop it. That is for type 1 diabetes. For type 2 diabetes, most likely compared with type 1 is adult onset and non-insulin dependent in most cases. There are two main problems related to insulin in type 2 diabetes. First is insulin resistance. That means that insulin does not bind with the special receptors on cell surface, and impaired insulin secretion. Insulin secreting glands release an irregular amount of insulin. So in practice, we have increasing level of insulin and high level of glucose. As you can see in picture this, yes, glucose comes to bloodstream. In normal, it's bound by insulin and utilized. In type 2 diabetes, yes, we have insulin resistance phenomenon, and as a result, high level of insulin and high level of glucose in blood. Stomach, that is again a picture as you see that how it works. Yes, stomach and small intestine break down carbohydrates in food to glucose. Glucose enter the bloodstream. Gastric hormone promote insulin secretion to response to glucose in blood. And the pancreas produce insulin, but as you remember, in type 2 diabetes, the body is resistant to its effect. So glucose is unable to enter the body cells effectively and stay in bloodstream, binds up in the and damaging blood vessels. So let me remind several words about how we classified diabetes. Type 1 diabetes, or immune or insulin dependent or juvenile onset diabetes. Diabetes due to insulin deficiency, and type 2 diabetes, combined insulin resistant and related deficiency in insulin secretion, and it's frequently known as type 2 or non-insulin dependent diabetes, adult onset diabetes. Then a special type of diabetes gestational diabetes mellitus developing during some cases of pregnancy and usually disappear after it, and other types of diabetes, secondary diabetes, like genetic defects of beta cell function, like genetic defects in insulin action, diseases of the exocrine pancreas, endocrinopathies, drug or chemical induced infections, some genetic syndrome that's sometimes associated with diabetes. So, one more time, remind you that the reason of development of type 1 diabetes, it's autoimmune disease, means selective destruction of beta cells by T cells, and production of some circulating antibodies against beta cells. It's caused by autoimmune attack. And in this case, both genetic and environmental factors are important. So, some viruses like Coxsackie, mumps, rubella can be trigger for diabetes, not the reason, but trigger for diabetes. Some nutritions like cow milk. So this environmental factor affected immune system and start the autoimmune, initiate autoimmune response to beta cells. So we have antibodies in game beta cells, and have in practice we have diabetes type 2. This for type 1, I'm sorry. And then for type 2 diabetes, we have two main mechanisms: B cells dysfunction and impaired insulin action. For B cells dysfunction, it caused impaired insulin secretion, and impaired insulin action caused decreasing of glucose utilization and also increasing of glucose production by liver. Response to insulin decreased, glucose uptake decreased, and glucose production increased. The mechanism of insulin resistance is not clear to the end. So, as we can see, both genetic and environmental factors are involved. For type 1 diabetes, genetic predisposition is very important. And some viruses, or as I said, only triggers for development of diabetes 1. And as you know, it usually starts from acute situation like coma or ketoacidosis, for example. And the trigger of it, we can determine some viral infections and some toxic reactions. For type 1 diabetes, the main risk factor is genetic predisposition that can manifestate with diabetes or not, depends from triggers. For type 2 diabetes, risk factors are family history, obesity and overweight, hepatic physical inactivity, hypertension, arterial hypertension, hyperlipidemia, previously identify impaired glucose tolerance or impaired fasting glucose that we actually can call diabetes. We can also put gestational diabetes in this risk factor group. So, as I said, The diagnosis of diabetes is not difficult, it's easy. We have some criteria that change from year to year, but in general, symptoms of diabetes plus casual plasma glucose concentration more than 11.1, or fasting plasma glucose more than 7.0, or 2 hours post-load glucose more than 11.1 during mean glucose intolerance test. Right now, as I said, we have additional criterion for diagnosis. It's glucosylate hemoglobin more than 6.5. As you remember, this test usually we use to control the level of glucose to be able to estimate the effectiveness of our treatment. But right now we put this criterion as a diagnostic criteria, one of these. So any one test should be confirmed with a second test, most often fasting plasma glucose. The criteria for diagnosis should be confirmed by repeating the test in a different day. So no matter what level of sugar you determined in patient, you need to make this analysis again to be sure to submit that this patient has problem. So actually it depends on it. For every test we need to do this. So only one, if we determine only one something wrong, so you need to check it at least twice. So categories of glucose status. One more time to be sure that you understand the terms: prediabetes, diabetes, and so on. Fasting plasma glucose. The normal level is 3.5 to 5.5 in capillary blood when you take blood from the finger, and up to 6.0 in vein blood when you take vein blood. Don't forget that it can be little more for patients older than 60 years, like 6.1, 0.2, 0.3. So the next thing, impaired fasting glucose. We have category of patients with high fasting glucose, not higher than 7, so 6.9, because you remember that 7 plasma glucose 7 means diabetes. So if fasting glucose 5 to 6 to 6.9, we call this impaired fasting glucose, and we need to supervise these people, explain them to try to keep diet. Sometimes it means taking off metformin, sometimes without it, but still need to be supervised. Then diabetes mellitus, fasting plasma glucose more than 7, and our post-load 2-hour post-load plasma glucose, or that we call oral glucose tolerance test. More than 11.1. So post-load glucose, the normal post-load glucose is 7, not more than 7.8 of millimole per liter, and impaired glucose tolerance from 7.8 to 11.1. Impaired glucose tolerance means pre-diabetes, actually. And 2-hour post-load glucose more than 11.1, we need to take the diabetes need to determine diabetes in patient. So, diagnostic criteria. First, level of sugar. Actually, first we can talk about clinical presentation or clinical symptoms, like polyuria, polydipsia, polyphagia, type loss for type 1 diabetes, and dry skin for both. And when patient have these clinical symptoms together with lab criterion, so we can determine diabetes. We already discussed diabetes. So, as a small conclusion of this part, but remind you what is diabetes. So what I want to say, that diabetes is not difficult diagnosis. It is not difficult to put this diagnosis. You need to combine patient symptoms, patient complaints, and make very easy lab tests. You need to check blood sugar level, fasting glucose. You need to check 2 hours post-load glucose, and you need to check glucosilate hemoglobin. It is pretty much enough to put diagnosis of diabetes. So, how will manage diabetes mellitus? Especially, you need to remember that we manage only acute situations supposed to be managed in the hospital or in emergency room, but the greatest part of patient with diabetes is a patient in polyclinic, not in the hospital. And actually your task is to make them still manage their disease in polyclinic at home and prevent acute complications. So the main 3 parts of management or treatment of diabetes are medical nutrition therapy, diet and exercise, oral hypoglycemic therapy, and insulin therapy. That is the 3 rails that and treatment of diabetes based on these 3 ways. And so you need to understand if the diet and exercise just enough to control blood sugar level, just fine. If not, so we add another kind of therapy. So the main point, the basic part of management of diabetes is to keep blood sugar level as close to normal as possible. So the main idea of diabetes treatment and management is to keep blood sugar level as close to normal as possible. And there is, no matter what way patient use to achieve this aim, diet is a very, very important part of management in every case, not only diabetes, but any metabolic disorder. Treatment cannot be effective unless adequate attention will be given to ensuring appropriate nutrition. That is a picture that in symbols show you what is more acceptable for patients with diabetes. So most likely the base of diet consists of green beans and starchy vegetables. And only on the top we have some sweets, fats, and alcohol. So for patients with diabetes, you need to switch the way how patient's nutrition. So dietary treatment should aim at ensuring weight control, providing nutritional requirements, allowing good glycemic control with blood glucose level as close to normal as possible, and correcting any associated blood abnormalities. We means triglyceride that they associate with diabetes mellitus. There are some principles or some recommendations that we can take as dietary guidelines for people with diabetes. First of all, dietary fat should provide 25 to 35% of total intake of calories, but saturated for intake should not exceed 10% of total energy. Cholesterol consumption should be restricted and limited to at least 300 micrograms or even less a day. Protein intake can range between 10 to 15% of total energy of desirable body weight. Requirements increase for children and during pregnancy. Protein should be derived from both animal and vegetable sources. The diet, as I said, very important part, yes, of. So 25 to 35 of total fat provide 25 to 35% of total calories, protein 10-15%, and carbohydrates 50 to 60% of total calorie. They're supposed to be complex and high in fat. And the second part of recommendation of lifestyle is physical activity, because it promotes weight reduction and improves insulin sensitivity, thus lowering blood glucose level. That's why we need to recommend patient physical exertion at least 20-25 minutes 3 times a week, or like gym or something like this. Together with dietary treatment, a program of regular physical activity and exercise should be considered for each person. And such as a program will be tailored to the individual's health status and fitness. However, people should be educated about the potential risk of hyperglycemia and how to avoid it. So, as much as diabetes is metabolic disorder, so the way to manage it is a complex of changing lifestyle, diet, and medicines, and insulin. Physical activity and diet is a very important part of management of diabetes. So if diet and physical exertion are not effective, so we start with oral anti-diabetic agents that currently can be divided in several classes, like biguanides, insulin secretagogues, insulin secretagogues, sulfonylureas and non-sulfonylureas, alpha-glucosinate inhibitors, thiazolidinone inhibitors, and DPP-4 inhibitors. That is the main group that we use for treatment. So what I would like to will not discuss the mechanism of action right now, but I would like to tell you about the main principles, how to recommend patient, what we need to put attention on. So if glycemic control is not achieved, and what does it mean, how we can check it? Glucosylate hemoglobin more than 6.5 and fasting plasma glucose more than 7.0. And how so if glycemic control is not achieved with lifestyle modification, and it means that hemoglobin, glucosylate hemoglobin higher than 6.5, fasting plasma glucose more than 7, and glucose tolerance test more than 11 millimole per liter. So we can wait for 1 to 3 months, and if it's nothing happened, we recommend patient oral anti-diabetic agents. Just if control, so it's in general situation, but if patient comes to you with a very high level of glucose, so it is better to start anti-diabetic agents from the very beginning. And one more situation, if diabetes patient starts from some complication of it, like blindness, so in the presence of marked hyperglycemia in newly diagnosed symptomatic type 2 diabetes, it's like hemoglobin, glucosylate hemoglobin more than 8%, fasting plasma glucose more than 11.1, or plasma glucose, uploaded plasma glucose more than 14, oral anti-diabetic agents can be considered at the outset together with lifestyle modification. So, if patient is not severe, you can start from lifestyle modification and diet for 1 to 3 months. If it doesn't work, so you add oral anti-diabetic agent. But if it is severe situation, you start right after together with lifestyle modification and diet. As first line therapy, obese type 2 patient consider use of metformin, acarbose, or TZD. Non-obese type 2 patient consider the use of metformin or insulin secretagogues. Metformin is the drug of choice in overweight or obese patients. TZD and acarbose are acceptable alternatives in those who are intolerant to metformin. If monotherapy fails, then combination of several drugs is recommended. If targets are still not achieved, insulin secretagogues may be added. So we start to manage diabetes slowly if the level of sugar is not critical. So, and we recommend it step to step. Combination oral agents is indicated in newly diagnosed symptomatic patients with glucosylate hemoglobin more than 10 and patients who are not reaching targets after 3 months of monotherapy, or probably if diabetes starts with complication. Коллеги, я лекцию читаю. So if targets have not been reached after optimal dose of combination therapy for 3 months, consider adding intermediate acting, long-acting insulin. So combination of insulin and oral anti-diabetic agent has been shown to improve glycemic control in those who are not achieving despite maximal combination oral anti-diabetic agents. So insulin therapy together with basic therapy of anti-glycemic drugs is indicated for patients who not achieve their target level of glucosilate hemoglobin and the patient with a level of glucosilate hemoglobin more than 10 from the very beginning. Combining insulin and the following oral anti-diabetic agents have been shown to be effective in people with type 2 diabetes. Metformin, of course, sulfonylureas, insulin sensitizers, its combination plus insulin, and glucosilate inhibitors. So insulin dose can be increased until target or fasting plasma glucose is achieved. So one more time in the picture, yes. If we're talking, of course, about type 2 diabetes, we start from diet and physical activity, modification of lifestyle. If it's successful, just fine. So don't remember that the main point of diabetes treatment in management is keeping blood sugar level as close to normal as possible. So if we did achieve this aim with the help of diet and physical activity, just fine. If not, we start medication in presentation, metformin plus agarose or metformin or insulin tetrahydrogenases. If it is meant for patient obese and non-obese patient. If it fails, so we can add insulin, long-acting insulin, and if it's failed, we switch patient for insulin therapy sometimes, most of the time together with insulin therapy. So as you can see, we start step by step. We manage diabetes, and I'll ask you to make 5 minutes break, and then we'll continue about the general guidelines for use of oral anti-diabetic agents in diabetes and indication for insulin therapy. So that is the way how we'll manage this patient in polyclinic, and most of the patients you will manage in polyclinic. Да, Инусик, звонила, говори быстро, офигенно сделала. Я лекцию читаю. Я же лекцию читаю, Лили, у меня же сегодня лекция. Слышишь, скажи мне, пожалуйста, что мне надо там купить? Ну, курочку, если только надо. А я грибочки куплю фукшет. Курочку купи. Купи, если знаешь, какие-то эти грудки на косточке. Если нет, значит нет. Ну и все, не надо смысла фукшет. Я кусками в духовке. Картошки купи, Игорь, немножко хорошей. Если будет, вот пару килограмм какой-то американки, или там чего. Вот, и все, больше ничего, я потом фуршет. Давай. I'm sorry, we can't continue. So today is a very nice day. Today is Friday afternoon. So I understand completely that all of us were waiting weekends. That's why I'll try to be short, but we still need to discuss some problems. As I said, I will try to put it in like 15-20 minutes. So, general guidelines for use of oral anti-diabetic agents in diabetes. In elderly, not obese patients, short-acting insulin secretagoras can be started, but long-acting sulfonylureas are to be avoided. Renal function should be monitored. So, don't forget that elderly patient can have, it's not the sulfonylureas are avoided, and don't forget to check renal function. Oral anti-diabetic agents are not recommended for diabetes in pregnancy. So the only one thing that we can allow for pregnant women is insulin therapy. Oral anti-diabetic agents are usually not the first-line therapy in diabetes diagnosed during stress, such as infections or surgery. So in this case, insulin therapy is recommended. It can be temporarily, and actually for any patient with diabetes, as you know already, all patients with diabetes, if they have some specific situation like infection, like surgery, like stress, they need to be switched for insulin therapy for this period and then come back to their regular medicines. Targets for control are applicable for all age group. However, in patients with another comorbidness, targets are individualized. And you need to remember that type 2 diabetes developed after 40 years, for example, yes, and as elderly patient, and a lot of patients have some more disorders to this age, so we need to think about this too. When indicated, we start with a minimal dose of oral anti-diabetic agents while rephrasing diet and physical activity. An appropriate duration of time from 2 to 16 weeks, depending on agent use, between increments will be given to allow achievement of steady-state blood glucose control. So when we recommend insulin therapy, of course, the start dose will depend from start level of glucose, but the increasing of dose is supposed to be slow. Insulin therapy. Short-term insulin use in acute illness, surgery, stress, and emergency. In pregnancy and breastfeeding. Insulin may be used as initial therapy in type 2 diabetes. in this situation. And in marked hyperglycemia, severe metabolic decompensation like diabetic ketoacidosis or another coma. So if we diagnose diabetes at patient, no matter type 1 or type 2, in this situation we start from insulin therapy, or we switch to insulin therapy if patient need to control sugar. Long-term insulin use. If targets have not been reached after optimal dose of combination therapy of diabetes, consider change to multi-dose insulin therapy. And when initiating these, we can stop insulin secreted nodules, but continue metformin or TZD. Insulin regimens. One more time about insulin regimen. The majority of patients will require more than one daily injection of insulin if good glycemic control is to be achieved. However, once daily injection of an intermediate acting preparation may be effectively used in some patients. Twice daily mixture of short and intermediate acting insulin is a commonly used regimen, and in some cases, a mixture of short and intermediate acting insulin may be given for patient in the morning for the dose of short acting insulin given before every meal, and evening dose of intermediate insulin given at bedtime before going to bed. Other regimens based on the same principles may be used. A regimen of multiple injection of short-acting insulin before the main meals, which in appropriate dose of an intermediate-acting insulin given at bedtime, may be used. Practically, when strict glycemic control is mandatory. So that is some types of insulin. So the main point how we divide it in short, intermediate, long, active. And why it is important to know the duration of insulin active. So you can explain the patient the schedule of meal. Rapid active insulin start to work in 10-15 minutes, have peak in 60 to 90 minutes, and act not more than 5 hours. This insulin usually taken right before eating or adding to in situation when the level of glucose is high. Rapid acting. Short acting analog. Short acting. So it starts to work in 30 minutes to 1 hour, has peaking to 4 hours, and durate 5 to 6 hours. It's taken about 30 minutes before meal or to lower high blood glucose. Then we have intermediate acting insulin. So it starts to work on set at 1 to 3 hours, has peak in 5 to 8 hours, and durate up to 18 hours. So most of the time we can give it as additional therapy at bedtime together with some anti-diabetic drugs, or it can be twice a day in regular twice a day. Then extending long-acting insulin starts to work in 90 minutes, onset in 90 minutes, and has no peaks and every 24 hours, and usually taken once or twice a day. So that is the very nice thing, yes, absent of peaks. So patient has got its usual schedule of meal. It also has its indication. Premixed signal while context a fixed ratio of insulin, and that is basically a combination of two kinds of insulin. Usually it's rapid or fast acting together with intermediate. And the first is in the name. The first is basal, and the second bolus insulin. So it's combination of bolus and basal insulin, and dosing depends on the combination. It's actually very easy, very comfortable for patient to take insulin like this. Then one more thing that you need to explain patient, especially when you will get patient with polyclinic, is self-care of diabetes. Patients should be educated to practice self-care. This allows the patient to assume responsibility and control of her own diabetes management. Self-care should include blood glucose monitoring with the help of glucometer, body weight monitoring, especially for obese patient and patient with deficiency of weight, personal hygiene, healthy lifestyle, healthy diet, of course, food care, have a physical diet and physical activity, identify targets for control, stopping smoking. As for physical activity, be careful if patient has some cardiovascular disorders or overweight and obesity. The high grade is very difficult for this patient to make physical culture, to make physical activity first. So you need to estimate situation any time. Monitor what we need to monitor. Most type 1 patient requires 0.5 to 1 kilo, and the initial regimen could be modified based on symptom, blood glucose level, and level of glucosylate hemoglobin. So all things you need to educate your patient. As soon as you will work in polyclinic or even in the hospital, you need to explain patient how to use glucometer. You need to explain patient what things he needs or she to avoid to prevent development of complication, and you need to explain patient what that the best way to avoid complication is to keep blood sugar level as close to normal as possible with the all possible ways. So complication, I would like to at the end I would like to very short to remind you about diabetes complicated, that is a specific situation that need to be controlled. So hypoglycemia, it caused by missing meals or intensive exercises, or most. The symptoms of it: tachycardia, palpitations, sweating, nausea, vomiting, progress to mental confusion. The treatment, of course, candy or sugar, IV glucose, and glucagon. Diabetes. So we talk right now about chronic complication of diabetes. Retinopathy looks like microaneurysm, hemorrhage, exudates with retinal edema. Diabetes nephropathy. As statistics says, in 30 to 40% of all first type of diabetes, nephropathy develops in 20 years. 15 to 20% of type 2 diabetes patients develop nephropathy, and it manifests as microalbuminuria, progressive diabetic nephropathy leading to end-stage renal disease. So, just make note that diabetic nephropathy, that is the beginning of the end, and it always causes development of, always needs in future dialysis. So, the best way to manage this situation is to prevent its development. All diabetic patients should be screened annually for microalbuminuria to detect patients in high risk of developing progressive diabetic nephropathy. Tight glycemic control and management of the blood pressure can significantly decrease the risk of developing diabetic nephropathy. ACE inhibitors are recommended to decrease the progression of nephropathy. One more chronic complication that we didn't mention, neuropathy. It's loss of sensation due to damage of nerve fibers, like heat, cold, pain, high blood glucose changing the metabolism of nerve cells and reduced blood flow. And as itself, it can manifest by orthostatic hypotension, diabetic diarrhea, and difficulty in urination. And of course, sometimes diabetic neuropathy accompanied with peripheral vascular disease and foot ulcer. The diabetes, that is the factor that always makes it worse. Incidence of gangrene of the fetal diabetes is 20-fold higher than control group due to ischemia, peripheral nephropathy, and secondary infection. So, combination of peripheral vascular disease and diabetes can cause high risk of gangrene, ischemia, and gangrene. Then type 2 adolescents, type 2 diabetes. It's increasing in adolescent. Lifestyle modification is essential in this patient. And if lifestyle modification alone is not effective, we of course start metformin, the only labeled agent for use in children from 10 years. And what we have for kids, we have only insulin. Then several words about gestational diabetes. Of course, that is the situation that can actually frequent situation. So what we need to for a pregnant, if we determine diabetes in pregnant women, we need to explain, so to recommend dietary control. If blood glucose is not controlled by dietary control, insulin therapy is initiated. And of course, it depends on the level of blood sugar. And we use combination of short and medium acting insulin or short and long acting insulin, and give it, depends from the level of sugar, twice time. Industrial regimen according to another serum. We have certainly less effective but required further studies to demonstrate safety. So, diabetic ketoacidosis. That is a really emergency situation. So, usually caused by missing insulin injection and the first time, and some stress factor surgery in patients with type 2 diabetes or undiagnosed diabetes can manifestate from the ketoacidosis. Signs: fatigue, nausea, vomiting, evidence of dehydration, vertebrate odor, very specific odor. If somebody can feel it, I'm sure I will not forget. Hypertension and reverse tachycardia because of hypertension and toxic. So, diagnosis: hyperglycemia, acidosis, low serum bicarbonate and positive serum ketones, abnormality, degradation, and patient education is important. Management. I don't think we'll not talk about management right now because we need to. You will discuss it on practical classes. But say just several words. Of course, fluid administration, IV infusion of insulin, potassium, and phosphatase. And the main part is to control. And prevention or delay of diabetes. One more thing that we need to talk is prevention, development of diabetes, delay probably of diabetes. Researchers have found that lifestyle changes together with diet can prevent or delay the onset of type 2 diabetes among high-risk adults, people with in group risk. These studies include people with intolerant, glucose tolerant, these studies included people with impaired glucose tolerance and other high-risk characteristics for developing diabetes. So, we can use primary and secondary prevention. Yes, primary prevention is to prevent development of diabetes at patients with genetic predisposition, trying to avoid risk factors of diabetes like hypertension, like obesity, overweight, and blah, blah, blah that we discussed before. Lifestyle intervention included diet and moderated density physical activity, like walking for 150 minutes each week. In the diabetes prevention program, a large prevention study of people at high risk for diabetes, the development of diabetes was reduced 58% over 3 years. So it is important. It is important. Studies have shown that medication have been successful in preventing diabetes in some population group. In the diabetes prevention program, people treated with the drug metformin reduced their risk of developing diabetes by 31% over 3 years. I need to say that right now there are a lot of clinical trials that confirm that metformin is the first line of therapy, except the situation what is called contraindicate. Treatment with metformin was most effective among younger, heavier people, 25-40 years age, over to 50 to 80 pounds overweight, and less effective among older people and people whose weight was less than 100, was less. Similarly, in the trial that about metformin, treatment of people with impaired glucose tolerance with the acarbose reduced the risk of development diabetes by 25% over 3 years. So this is actually, we can call already secondary prevention. So I mean that primary prevention is trying to stop development of diabetes by using this measure. So that is the example of primary and secondary prevention. Other medication studies are ongoing, and in addition to preventing progression from impaired glucose tolerance to diabetes, so as impaired glucose, high level of glucose, we call just risk factors for diabetes. Impaired glucose tolerance right now we can call prediabetes, and to prevent development of diabetes from impaired glucose tolerance is of course in the secondary prevention. And in addition to prevent progression from impaired glucose tolerance to diabetes, both lifestyle changes and medication have also been shown to improve the probability of converting form of impaired glucose tolerance to normal glucose tolerance. So, thank you for your attention. And what I would like to say at the conclusion, that diabetes is a widespread disease. It's a huge problem for a lot of people. And it's pretty easy to determine, diagnose it. And it sounds like it's not difficult to manage it. So we combine physical excursion, diet, some nutrition recommendation together with oral anti-glycemic drugs and insulin. And one more thing that we need to explain patient is important to control diabetes. And the best way to manage diabetes is to keep glucose level in blood as close to normal as possible, and use any way is acceptable. So I would like to wish you happy weekend, take some rest, and we'll see with some of you on Monday. Have a good day. You're welcome. I hope to see you next time. Bye bye.